Part 5. Why emergency rooms are overwhelmed and it's not abuse. Emergency rooms are often described as being overused or abused. It's a familiar claim and an easy one, but it's also an incomplete explanation that misses how people actually experience healthcare when something feels wrong. To understand why emergency departments are overwhelmed, we need to look at how decisions are made in real time, not how they look in hindsight. The decision most people are asked to make. Imagine a sudden health issue. Pain is increasing. Swelling is obvious. The cause isn't clear. It's happening now, not next week. Is this urgent care? Is it the emergency room? Is it safe to wait? Most people were never taught how to answer those questions. Take something as simple and as ambiguous as a spider bite. It's swelling. It looks alarming. It hurts more than expected. Infection is a possibility, but not a certainty. Is that urgent care or the ER? For most people, the safest choice feels obvious. Go where help is guaranteed. That instinct isn't misuse, it's risk avoidance. What emergency rooms are required to do under federal law, AMTALA, emergency departments cannot turn people away based on ability to pay or perceived severity. If someone shows up, they must be evaluated and stabilized if necessary. That obligation is essential, but it also means ERs become the default safety net when other options are unclear, unavailable, or delayed. Why the ER becomes the catch-all. Several structural factors push people toward emergency care. Limited primary care access, especially after hours or in rural areas. Urgent care boundaries that aren't well explained or intuitive. Insurance rules that complicate same-day care elsewhere. Fear of missing something serious. When symptoms escalate quickly, in those moments, people aren't choosing the ER because it's convenient. They're choosing it because it feels responsible. The mismatch. No one talks about emergency medicine is designed for stabilization, not continuity. That means the problem is addressed, not managed. Long-term follow-up happens elsewhere. If it happens at all, the ER absorbs pressure created upstream in the system. When primary care access shrinks or urgent care becomes ambiguous, emergency departments feel the strain. This isn't random, it's predictable. Reframing the conversation. Blaming patients for showing up doesn't fix overcrowding, it just ignores why they came in the first place. Most ER visits that later get labeled non-emergent only look that way after a clinician has evaluated them. Before that evaluation, uncertainty is real and fear is rational. Understanding this doesn't excuse system inefficiencies, it explains them. In the next post, we'll untangle another common source of confusion, the assumption that insurance is the same thing as healthcare, and why that belief quietly shapes access, delays, and frustration throughout the system.